I said thank you to all people with MS who come. But this event wouldn't have been possible without the active and wholehearted involvement and enthusiasm of MSSI, Multiple Sclerosis Society of India. Bipasha and all the others so committed. I mean, I've been known this group for now probably maybe more than 15 years, and they stayed cohesive, and they've just gone from they have met face to face. And I must really comment on the bravery. I should say that they've been brave enough to get off the shackles and come out here and connect. And I think it's a good feeling now to connect, isn't it? The human touch was lost, and we've been living in a virtual world. This has been great. So good start. And I think by next year, we will have this hall full of people not with problems and disabilities, but active members to be able to contribute in some constructive way to contribute to even to understanding what is region specific, what is Hindustan specific, so that we also can become Atmanirbhar as well as showcase to the world. Said that, I want to very quickly go through some advances, and this may be of some relevance to the MSSI group as well. Just I tried to put in some concepts which have got more clarity, and also some aspects which have really helped us gain confidence. And it's, I would say, from what we have been from 1993, when the slate was blank, you could do nothing. You diagnose and then say adieu. To now, it's an exciting time to be in. So we have got understanding that MS looks as complex as this. There's a part of a brain, and there are these numerous, those portals that have been highlighted are the areas where you can target by using medicines. So it's not one target, there's several. So that's one advance we have. That means it is very heterogeneous. It's not like pneumonia and there is a pneumococcus bacterium which is causing it. This is a multifactorial disease. This is heterogeneous. And the heterogeneity is expanded over the clinical aspect. So we do have a 16-year-old girl who's just had a loss of vision in one eye and doesn't have another attack ever next 5 years. And there is a 20-year-old boy who's had a vision loss, and then afterwards 3 months he has a paralysis, and another 3 months he has urine problem, another 3 months he started to have a disability, he can't walk without support. Now that's also you're aware. And then there is a 40-year-old who's never had a problem till 40 years of age, and then gets on to have this progressive problem in walking. Nobody understands why. So that's how heterogeneous this disease is. It is never so uniform. How do you expect that one drug will fit all everybody? It's a no-brainer. So obviously it's one glove fit all will never approach. So that is a basis for what is called as a personalized medicine and a precision medicine. That is one advance that we have. So we have this mechanisms of action drawn out for a lot of medicines that you also understand. You heard of dimethyl fumarate, tecfidera, difira, whatever, you have teriflunomide, you have interferons, you have glataramar, you have natalizumab, that is Tysabri, you have Rituximab. All these, whoever is afflicted with MS, you understand these terms because these are the medicines you have in your arsenal. So all their mechanisms have also been now known how they act. So we have a better understanding to deal with their side effects. So whether we need to treat early, again, this is clear. We must treat early as soon as a diagnosis is made. Okay? It's no longer a rocket science. There is no ambiguity in that. Why? Because when there is a diagnosis is made, this is when a diagnosis is made. This is this is clinical. Okay? But by the time something is obvious in your face, there is a whole lot which has already happened below the surface. That's the reason we say MS is an iceberg. It's a tip of the iceberg that is visible. There's a big chunk which is not visible. Therefore, by the time there's somebody who's come with a complaint, it's not really early to me. There's a lot which has already gone on. So don't think that abhi to शुरुआत हुआ, it's okay. Vision की problem थी, अब तो ठीक हो गया. Now let me wait for another problem to happen. I may not have it. This is an early disease. I have got so many side effects with these medicines, so let me not start treatment. So that's now we know is wrong thinking. You must start early. And we also now know that when there is a problem, EDSS, how many of you understand the term? A lot of you understand. This is a disability term. We don't want that 3 to come. In fact, it is 3 to 4.5. Because if there is a disability at that level, from there to reaching on to a level where you need something to walk comes very early. It's exponential. If somebody is taken 15 years to come to grade 3, it takes maybe 6 months to come to a stage where you come onto a wheelchair. We don't want that. We don't want that 3 to come. All right. So for that, again, it is heterogeneous. There are some who reach 3 in 6 months. There are some who reach 3 in 15 years. So can I give the same medicine to this 15 years 3 to the ones who coming in 6 months? Time is brain. So time is brain not just for a stroke or a brain attack or for having multiple seizures or a viral encephalitis or got COVID. Time is brain for even multiple sclerosis. So I need to hit them hard when the disease is bad in somebody. Okay. And we also have now known that the advances that beyond a disability of leg, हाथ पैर काम नहीं कर रहा, or there is a problem in urination, there's a problem in balance, there's a problem in vision, there are problems in thinking, problems in behavior, problems in memory, problems in executive function, problems in judgment. That sometimes is not even obvious. The person's personality is changed. Besides depression, there's someone who's garrulous, who loses the insight into the illness. Those are cognitive changes. They need to be addressed, and we know MS can cause that. Earlier you address them, earlier you manage them, then they remain their normal selves and can lead a normal life. Again, this needs to be seen very early in life so that you can tackle it. There's another thing which we now know definitely. So early treatment, there is a window of opportunity. And if you miss that, for something like a window of opportunity, to 100 to 50%, it goes down to nil if the time elapses. So this is established. This is part of the advance in terms of actually knowing the clarity. Now, as regards, there was a question Vipasha asked me to cover that thing about why MS happens. It's still gray. We still do not know. There are a lot of things. Genetic, there's climate, there's environment, there is so on and so forth. But viruses have always been seen as triggers. And the role of Epstein-Barr virus was always there. But it is just recent that there has been more robustness in that evidence that EBV infection may be one of the triggers. When there is a predisposition, when there is an ongoing problem, it triggers to have an acute relapse. So that is one of the other, again, a little bit of one step forward in advancing the trigger to this attack. We want the DMT, so disease modifying therapies, to do all these things for us. No attacks, or if there has to be an attack, let it be after a long period of time. Minor attack, and even if there's an attack, let me recover completely. No disability whatsoever. And when I want the MR, they should be clean and no spots. That's reaching a state of utopia. But that is exactly what we want our disease modifying therapies to do for us. And so we have this pyramid. Okay. So in the pyramid, there are some things which I have put. These are all clinical. That means number of attacks and disability. These are the two things you know of. Disability is walking problem, needing somebody's help to walk. Disability is stiffness. Disability is having to go to washroom time and again. Disability is inability to see properly. So disability is an impairment of your daily function and needing assistance for that. So no disability, no relapses is what is called as no evidence of disease activity, called NEDA. So NEDA is a concept now which is now got crystallized, that what we want when we treat a person with MS is we want to reach NEDA. And NEDA has been classified. एक तो clinical है जो I told you about attacks, about disability. And then we bring in MRI. A lot of you have had MRs, and in MRs we look at spots, we look at what is called as holes, which are old spots. The spots can enhance, of course, with contrast. And then we also have to look at the whole brain volume. It shrinks, called the atrophy. So these are the parameters of an MR. So the first one, no spots and no black holes. Now that's enough for me to make it into NEDA 3. And then we put in volume. There is no atrophies, NEDA 4, great. And there are certain biomarkers like, biochemical, which you see in blood, in CSF, called NFL, which are neurofilament. This one is not being done very extensively. There's just probably one couple of private labs which are doing it. We are not doing this. But why I put this up is that the extent of no evidence of disease in the body is getting refined and refined and refined. But what is impactful to us is there should be no attacks, no disability, and no fresh problems in MRI. Simple. So keep it simple. In our clinical practice, we want that is NEDA. And to achieve that, you have several ways of dealing with it in terms of disease modifying therapy. And that's the pyramid I'm talking about. That when you look at a pyramid, all these questions happen. And when a lot of you may have questions, should I start treatment? If I have to, when should I? When should I shift from one thing to the other? And how long to continue? That's a very frequent question, isn't it? Once I'm on medicine, doctor, do I have to take it lifelong? How many years do I need to take that? And then if there is a problem while on one medicine, what do I do? What about pregnancy? What about childbirth? What about marriage? What about career choice? What do I do with this? So these are inherently, integrally very, very important questions. And all of them, we don't have very straight answers, but a very sincere and honest dialogue, we will be able to get some solution to individual. Again, remember, the treatment is personalized and precise. One glove fit all won't really, So, but then when you look at the panorama and what has happened in the slate of management schedules for MS, it's really very, 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 I must say, very empowering. Because there's nothing beyond 93. And now look at it. We have 14 on board and there are 5 on the annual. And probably 3 which are not there in India, which are there abroad. So on total, 17 already on board. So sometimes I feel we are spoiled for choice. So, you have so much in your arsenal that you can manage at whatever stage the MS person can come to you. So if you're looking at it and then you say, ki, Acha, to itne sare hai, so which one is better over the other? There have been some definite studies which compared, contrasted, what we call as network meta-analysis. There were 2 such things. I'm sure some of you must have heard of a name called Cochrane. It's a library which does most of this meta-analysis. And then they found this, the sketch of treatment. Most of you know these drugs, okay? Whether it is interferon, teriflunomide, glatiramer, dimethyl fumarate, you have fingolimod, rituximab, you have the natalizumab, mitoxantrone, alemtuzumab, and up there is stem cells. So whatever is green are nice level 1, we call as platform therapies. Their efficacy is there, mild. So side effects there, but mild. So they're nice, safe, mild drugs. So best option किस में देंगे आप? So nice, safe, mild disease, right? So that is one group of MS where the disease is mild, maybe I will choose that. And then you have these orange guys. So they are moderate efficacy and moderate risk. And up there are those red guys, those are very efficacious and have high side effects, which is not difficult to understand. That's how even cancer therapy is, isn't it? The bigger the drug you use, more the side effects. So the choice in a particular person, you have to weigh the balance. Does this person require this high-end therapy, which will justify the side effects? Because somebody who deserves highly effective therapy, I can't choose these mild drugs. That's useless. Then what will happen? The first 6 months going to 3, they'll come to that. And after that, if I start giving them whatever it is, it doesn't help because there is a switch. They're going to exponentially go up to 6 and they'll come to understand. So that is the reason we need to have a very personalized treatment. That's been the advance in understanding. And the course of MS definitely has been modified. In 1990, this is the graph. It just went up and up and up. That's the kind of people, it was something here that at the end of 60, by the time they have come to some 20 years, almost 100% were in a wheelchair. But now it doesn't happen. In 2011, it's just about 20% who are in a wheelchair after 25 years of MS. That's the kind of change because of the advent of all the disease modifying therapies that are there. Now, this is more for my DM students. Obviously, I don't see anybody there. But here you have a concept called induction, it's a concept called escalation, and a maintenance. Escalation means you're going step by step up. So I start with very minor therapy. Problems hai, I go a step higher. Usme bhi problem hai, I go up a step higher. Whereas induction is bad disease, boom. I really have to really, it won't be a shot with a cannon. And then once the disease sort of burns out and comes down to a smoldering level, then I bring in maintenance therapy. So this is how you play across the induction, escalation, and try to maintain the immune balance, but understand it's an autoimmune disease. Okay? And for that, you have several of these medicines, which on the up, you have the development of all these drugs called platform therapies. Platform therapies are level 1 are your interferon, glatiramide, teriflunomide. DMF is still there, but DMF has a little bit of more efficacy than a platform. It comes somewhere in the middle. That means it's highly efficacious, but safety is good. And then you have level 2, which is natalizumab and fingolimod. And above that, somewhere in the middle is rituximab. We don't have ocrelizumab, we don't have ofatumumab and all those things. It is approved. Ocrelizumab is not available here at all. And then you have alemtuzumab, and then this mitoxantrone was an old drug. I don't use it anymore. It's got a lot of side effects. And then you have stem cells. The last slide will be of stem cells. Below, I have the listing of how our assessment of disability is also changed. Simple things to become more composite. We've added on memory, added on behavior, trying to understand comprehensively an MS composite of an outcome as well as disability in a particular person, and the changes which have come in guidelines, whether it is AIIMS, whether it's European, whether it is, Pacific, whether it is Pan-American, whatever it is, the guidelines which also have changed pari passu with all these advances in understanding and improvement in our arsenal. So when somebody comes and says, what treatment do I need? Inactive MS is when there is no relapses. There's no activity. You have NEDA in 24 months. So 2 years NEDA. There are some who actually stop. I don't. I would prefer it to have, like, I stop only when somebody's crossed the age of 50, 55 and has been NEDA for 5 years, that I take them off if they've been okay on a medication. But a lot of people across the world, if NEDA for 24 months and there is a choice, then the NEDA then the DMT may be off. But when there is any relapse in the 24 months, some MRI activity, that means there is no NEDA there, you continue. But you're continuing on level 1. But if there is much more activity than that, then you have to go to level 2. But the trouble is, the bang in the middle called rapidly progressive, the really malignant MS, it's not giving you any time for any respite. You give steroid, they improve a bit, but then some disability is left over. They don't improve in vision. Some improvement, then they stay on. Those guys will need definitely level 2, level 3 bang on. So that is called high aggressive MS. That's again another advance. So that is what is called as a flipping the pyramid. The pyramid is like this. We start baseline, then go step, another step, but here we are inverting it. And we start with the most effective, but has side effects, and then come down gradually. So that is a flipping of the pyramid, which has also been now chosen to be a definitive therapeutic paradigm for a highly aggressive MS. So, what constitutes a treatment failure? For us, if they continued attacks, for me, there's a continued increase in disability and MRI showing activity. Keep it very simple like that. There are several other things, but for you and me, simple, so equation will be: I have relapses, my disability is increasing, my repeat MRI is showing activity. That's it. That means the treatment is not effective and you need to shift. And there are a lot of scores which have been described: Rio, modified, Magnums, what have you. You don't have to remember these names, but they essentially map out these ways and also give you a kind of a MS decision model. But for me, I think the decision model will also entail a serious, honest dialogue between the caregiver, the patient, or the person and the physician, because it has to fit your pocket. We don't have a national insurance. It has to fit your lifestyle. Somebody doesn't want to eat a tablet every day. Somebody doesn't want to take an injection. It's very horrible. I also don't like injections. I mean, there is a prick. And there will be some who will continue to have fever and myalgias when they take interferon. They just simply don't go away. There is fatigue. 2 days in a week goes. And I don't want to take an injection every week. So some will say that let me take 2 injections and see 6 months and be done with it. There's some who say, monthly I will take an injection. So it depends upon your choice, depends upon what your profession, career graph and lifestyle is, depends upon your pocket. Are you paying for it? Is insurance paying for it? What is it actually that you need to do? That will ensure your compliance. And then look at what is the best treatment strategy out of all the things that I have. If I have a level 2, I have Natalizumab once a month. It is effective, but it is costly. There is Fingolimod, everyday tablet. It has its own problems, but we have a generic and it is pocket friendly. So I will choose, right? So the choice is with the dialogue giving all these options. So that is a decision model. This is an algorithm which has always been there, wherein when a person with MS comes, we position that patient to which category the person is. Is he in this, the position where they're very mild, versus someone who's going to be a very aggressive multiple sclerosis? Then choose the therapy. In an aggressive MS, I'll start off with something which will reset the immune system. Such an autoimmune process is so malignant and belligerent and aggressive. I have to reset it completely and then come down. Whereas the other way, which is not so very malignant, maybe I'll try and tweak it and give it a little more medication so that that autoimmunity can be at bay. So that is how the strategies go on. Now, supposing there is a 17-year-old girl. She's a first-year university, had one optic neuritis. You're all aware of optic neuritis. There's a vision loss. Took steroids, did well. Then what happened? Well, first was myelitis. Us samay kuch kiya hi nahi. Then had optic neuritis. Then she was started on interferons. It often happens after a first attack. A lot of people don't. They say clinically isolated syndrome. Some don't want. Ek hi to attack hua, abhi to theek hai, kyun? We will wait. Anyhow, this girl was put on interferon after 2 attacks. She did okay, but promptly the next year she develops a clumsy hand. Remember, some of those complaints in MS can be very vague. You don't even know whether they are actually attacks or not. And then there was some pins and needles. Then she had an optic neuritis again. Then what happened? So she had to be put on what is called as Natalizumab. When is Natalizumab coming in? Level 2. Now, in this condition, after she's been on Natalizumab, she went into Nehra. But there was no evidence of disease activity, like no more attacks and no more increased disability. But the residual effects have remained. What has already been accrued, it is known that sometimes even they may mitigate, but they may not go away. But what if I had positioned this Natalizumab straight up in the beginning itself, say when something here, somewhere here itself, when after interferon she developed clumsy hand and pins and needles, I position here itself. Or after another optic neuritis, I don't wait till this brainstem syndrome and all this happens. Then maybe this disability won't have happened. So it depends on when you position your other drugs. Okay, so time is brain. And now very few, little about highly aggressive MS. It is a known entity. highly aggressive multiple sclerosis may look vague, but it is not. There are a lot of risk factors. Now, essentially, those who are males over the age of 40 years, and there are some racial ethnic populations who are more predisposed. What happens is that there is an attack which is very severe, and they quickly come on to disability. Steroids don't seem to be doing much. They get recurrent hospitalizations, and they're multifocal. That means they have an eye problem, they have a bladder problem, they have a leg problem, all happening in one go, and something which is not recovering. And the MRI shows a lot of lesions, lot of activity. Spine may be lesions, say brain may be lesions, say this is one big red flag. If such a person is coming to you, then I'm not starting them on platforms. I'm going straight to probably level 2. I will give them an option, and maybe a lot of them may, because of pocket friendliness, they may choose Rituximab. Some, if they have insurance, they go to Natalizumab. But this is the kind of people I'm not starting with a platform or level 1 drugs. So it is important to identify this highly aggressive MS, because they quickly come on to a disability and you may not be able to, do that. That's a therapy protocol. Is it ever too late to start DMT? No, never. Please, you can start your disease modifying therapy irrespective of your thing. If you're 50, 55 and nothing is active, it's only disability which has been there for several years, that's a different matter. But even there would be some therapeutic strategies. But it is important that when you're choosing a therapy, when you have to flip a therapy, we're not waiting for a lot of time. We're doing it much, much, much early. And so the last thing that I have to talk about, as I said, this is a shared treatment decision. So right therapy, right patient, right time is the basically mantra. This is what we target, and this is what we want your compliance, because unless you come to us in time, we won't be able to do that to you. So the last of it is, of course, the stem cells. Just wanted to bring this up because it's always been a favorite question, and there are people who come and say, doctor, let me get a stem cell treatment and I'll be done with it. My immune system will be reconstituted and I won't need any medication at all. We haven't got there yet. But I do understand that MS is one disease wherein maybe we will be getting good guidelines on stem cells and what exactly is the stem cell treatment. Not some blessed injection given subcutaneously. It's a bone marrow transplantation. And there is a lot of research also on other methods of stem cell medication. It's a way forward. There is a lot of hope on that. But at this point of time, it can't be offered as a treatment to everybody. We can only give this as an option to some, wherein they're not doing well on the usual course. They are also aggressive. They come under that aggressive multiple sclerosis. But it should also be not such a case wherein person is already in bed and has an EDSS of more than 6.5, is dependent and has been there for several years. Such a person, it may not, it will give you a wrong indication. It won't help and you think the stem cells won't work. So therefore, this is definitely a way forward. Hopefully, we will be getting answers to when to position stem cell management and what kind very soon. So getting the right drug to the right patient at the right time. Thanks. Okay, so this is done, and I think now we take up the panel. Yeah, if you have online questions, we can take that as well.
Can we have the lights on? Okay, thank you, Professor Padma, for this wonderful overview of the advances in management, and I'm sure that covers already most of the things which colleagues have asked online. So we had quite a good response coming online about the questions, and I'm happy to say that most of the people have at least on a median of about 8 questions correct out of 10. So I think we do have a very well informed group of patients. So that's really good to know. And we're still getting more responses as well. So Based on what we got from the YouTube, which are still coming in the questions, there are few sets of questions that are come in and we can discuss. And then for some of you who have come in person here, have the freedom to please raise your hand and ask any question that is seemingly very important, so that we can take it forward as well. So one of the questions that has been asked by some of the people online, Rajeev, this is for you, that a lot of them feel the issues with walking, that they have walking issues. So what can they do to make it better? Although it is not elaborated, but it is a more general thing. So if you can just put some light on what would you recommend, what they should do.
Yes, walking is a concern for many of the multiple sclerosis persons. Uh, the reason can be many. It can be the stiffness, that we say the spasticity. It can be the weakness that is causing them difficult to walk. It can be the sensory symptoms, that they are not able to perceive the sensation in the feet, or it can be general fatigue. So we have to differentiate what is the factor that is contributing कि वो walk करने में उनको problem हो रहा है. सबका management possible है provided कि diagnose properly हो जाए. अगर तो stiffness है, spasticity है, so they might be taking some medicine as prescribed by the doctors, जैसे बेक्लोफेन मेडिसिन देते हैं या कुछ और मेडिसिन देते हैं. और अगर वीकनेस है तो उसमें स्ट्रेंथनिंग प्रोग्राम उनको हेल्प करेगा. और अगर सेंसरी परसेप्शंस की प्रॉब्लम है तो समटाइम्स सेंसरी री एजुकेशन ट्रेनिंग ऑल्सो हेल्प्स देम टू रिकवर. वेट बेयरिंग कराना, प्रोप्रियोसेप्टिव ट्रेनिंग कराना, उससे उनको इम्प्रूवमेंट हो सकता है. और फैटीग अगर है तो उसके अंदर हम उनको कुछ एनर्जी कंजर्वेशन टेक्निक्स के बारे में बात करते हैं, पेसिंग के बारे में बात करते हैं, एक्सेसिव टेम्परेचर में नहीं रहना है. ये कुछ स्ट्रेटजीज हैं जिससे वॉकिंग इम्प्रूव की जा सकती है. अपार्ट फ्रॉम दैट दे कैन टेक द हेल्प ऑफ सम वॉकिंग एड्स लाइक स्टिक्स और क्रच, और द if required then some other devices like walkers and other things can be prescribed for them.
Okay, thank you, Rajeev. So I think you have concentrated upon first what exactly is the walking difficulty that needs to be known, and then a complementary approach from the neurologist and a rehab specialist to help make their walking better and aid it better as well.
Yes.
So another question, and I would ask Dr. Padma, because she's recently covered, is about people's query about is bone marrow transplantation and stem cell transplantation is the same thing or it is different, and what is its usefulness as far as MS is concerned specifically?
Very intelligent question. In fact, bone marrow transplantation and the stem cells is not sine qua non, so they're not same. Stem cell therapies are of several kinds, one of which is bone marrow transplantation. In bone marrow transplantation, what you do is you harvest some cells, then you ablate, means you destroy the bone marrow, and then you repopulate the bone marrow, giving the cells back with some additive. There are other what are called as some neurotropic factors and other things. This is something which is done routinely in hematological malignancies. However, as a therapy point of view, there are a lot of studies in multiple sclerosis, and we probably will be getting more evidence. The evidence seems good. But at the same time, there are other stem cell therapies which are from the bone marrow. You take out some cells, you can culture them, or you can give them by what are called as naive mononuclear cells, which are given by a good stem cell facility, and they're given intravenously, they're given in other ways, and these are supposed to be several varieties of the way stem cells are given. In a lot of diseases the research is going on, so also in MS at this point of time there is no evidence to say that that is definitely going to come as a so grade A recommendation or that is part of a treatment of MS. It's not there yet. Maybe in future, at this point of time, it's not there.
Thank you, Professor Padma, for elaborating on this frequently asked question by our patients. So, I would ask now Dr. Rajesh, there has been quite a few online questions regarding the use of rituximab in MS. So, their questions have been about the duration of treatment and how frequently we should be using rituximab routinely, and about its general use in MS patients. So could you please elaborate about its use and about the frequency of its use, how frequently they should use it?
Rituximab actually has been used as an off-label treatment in multiple sclerosis, but in various studies also it has been shown that it improves or it decreases the lesion load in the MRI and clinically also, but we are still using as is an off-label treatment only. Yes, and the evidence is growing. Maybe it can after that some time when evidence is proper, it can be used in the MS. Right now, we are using it as only in certain special circumstances and as an off-label treatment. Injection is used mostly. Infusion it is given at 6 monthly interval. And again, the duration will depend in the situation in the disease activity of the multiple sclerosis patient, and then we can decide the duration for which it is being used.
Thank you, Dr. Rajesh. So, rituximab is being used in the treatment of MS, and the choice of using of rituximab is patient-centric at the time that you require it and after due explanation, and the frequency on an average is somewhere between 6 to 8 months, as Dr. Rajesh also said. But sometimes we would use biomarkers like some blood tests to decide whether we can do it every 6 months or we can push it back by 2, 3, 4 months to just, lessen the risk of immunosuppression. So it's a pretty individualized approach. The other question I would now ask Ashima, there are lots of questions, in fact, that people have talked about their concerns related to anxiety, their concerns related to concentration and mood swings. In fact, there have been quite a few, queries on the perception and feeling they get about being anxious, about their mood swings, concentration. So could you please just elaborate on that as well?
MS, as we know, is a disease which starts early in age. Many of these individuals, who happen to be mostly women, have various associated concerns, and especially those who are not married. So the concern is, will I get married? Will I be able to have a normal life? Will I be able to bear children? Will I be able to look after household activities? And if a person is in 20s, the concern about, would I be able to get a job? And those who are on a job, the concern is, would I be able to sustain in a job? There are predisposing factors and the precipitating factors. The predisposition is the way we all are, of course, is a normal thing. But what is important is that one must talk to one's clinician, especially the neurologist, the medical doctor. The first person with whom you're having your contact is the right person who would be able to reduce your anxiety by giving you right knowledge. The worst thing that the patients tend to do is go to internet, get information from wrong sources, and then they form an opinion which just becomes one final opinion which they're not ready to share with anybody. Hence, eventually it leads to mood disorder. One gets into a shell. One is not able to talk to anybody. So first, most important thing is you talk to your neurologist. The neurologist henceforth is able to take away a lot of your problems and would be a right person to send you to a right mental health professional who would be able to evaluate you, would be able to identify. Of course, as studies are proving that cognitive disorders are common in these patients. They have problem in focus and they have fatigue. So to get away with the focus, and it could be because of the medicines, which again your neurologist is the right person to tell you that it is because of this and it is for a short while. And a proper assessment, a cognitive assessment, will tell you where the problem is. And as we see, the patients actually have 5 things which is most concerning, which is the social, the vocational, the personal, the cognitive, and the family. When I'm saying family, if one is just been married in one's 20s, the concern is the marriage, and to sustain marriage, will I be able to continue in this kind of a marriage? And when it comes to vocation, the concern is again the paramount, because the concern is, would I be able to carry on with this job, or will they chuck me out? And social, because in our Indian setup, we have a very nice knit social network with good family. But one feels that I'm just sitting somewhere, people are gradually not talking to me, and which leads to depression and concern. So hence, most important is, please, if you have any such concern, the first person you must interact is with your neurologist.
Thank you, Dr. Ashima.
Can, do we have any questions from, yeah, please, Vipasha.
If they go through the stem cell, does it help them stop the progression of MS? This is what they want to know. They want to go through stem cell to stop the progression. Is it right that it stops the progression?
No. See, again, the stem cells at this point of time, it is the management is positioned into a immune reconstitution therapy. So it's again positioned at that level where you are rebooting the immune system in the hope that whatever process has driven this autoimmunity is reset. But the disability which is accrued will probably remain. That's one. So therefore, there has been a voice that let's not give it when the disability is already a lot, try and give it somewhere in the middle. Since we don't know everything about the stem cell treatment, you understand that even in hematological malignancy, when they ablate a bone marrow, it's a dangerous period. It's a dangerous period. And across different clinical practice setting, especially in a developing world, it's not easy. So before you can give a sort of a guideline, they have to look at the safety factor, which has not been proven yet, as against that, whether it will be completely efficacious. So what you asked is true, that a lot of patients come and say that I want to get rid of the disease. So reboot my system, and the stem cell is one way of rebooting, therefore let me go through it. The hypothesis is great, but we don't have evidence as regards does it really do that, and how safe can we do that, the procedure. So therefore, at this point of Bipasha, I would say desist with it. But maybe a couple of years down this lane, we may actually have that coming in, which can be applied across different practice settings. So at this point, we should say no, because the reason I'm saying that also is, especially in India, we have a lot of centers who are saying we're giving stem cells. And when we say this, they take this and they say, oh, okay, stem cells has this benefit, and they'll go to the closest center which is saying we are giving stem cells. And there's no control over those. Control over the efficacy, the safety, and the guarantee, and what we call as good clinical practice is there as it should exist. So I think approved places and with guidelines in place is of paramount importance. Till we get that, we are not saying go ahead. I can't hear you.
Fortis Hospital, they are constantly doing this.
Huh?
Fortis Hospital, they are constantly doing this, Dr. Bhargav. So I don't know what opinion you have, because a lot of people want to go and do the stem cell with the hope that whatever has happened, it should stay there. They shouldn't progress.
If I can
it
bring you, Bipasha, you were there when we had even this so-called stenting business. When everything was said to be, you just stent off the jugular. Do you know that? And people came from abroad to places in the private sector. I'm not going to name the sectors which have done that. Again in Gurgaon, in Delhi. And they had done that. And you now realize that couple of years down the lane, in fact, a lot of the places, especially in the US and Europe and Canada, they were actually closed. They had to face criminal charges, which of course will never happen in this part of the world. But and it died. That whole concept died and the procedures died. But before it actually went in, do you remember, Rohit? There were hundreds of people who actually made a beeline from the US, Canada, and came down here to Gurgaon to get those procedures done. So I'm not saying that this is right or this is wrong. We do not have scientific evidence to back it up. Till as such time, I will, as sitting here as a person with some science background, I cannot endorse it. I need more evidence to say that.
Thank you, Dr. Padma. Ela, I would like to ask, yes? Yes, please.
How can cognitive disability of a MS patient after she has undergone HSCT be dealt with? And the other question I want to ask is, how can
One moment. After stem cell treatment,
after HSCT, hematopoietic stem cell therapy, how can cognitive disability be tackled? And one more question is, if that particular patient is wheelchair bound, how can the ball and urinary problem be
right.
sorted?
Okay, so Ashima, you want to take up cognition issue? About, I mean, this is more pertinent for rehab.
Yes. So there is RCT which has been done on MS, and a cognitive retraining program has been developed, which is an 8-week program. And right now, Professor Rohit and Professor Padma, they are planning to have a robust program for AIIMS as well. So it is an 8-week program with the patients having a contact with the person once in a week, and it is a home-based program. What is important is identification of the cognitive disabilities or the disorders, or if they are alarming, which needs to be focused on. So we, from a psychology point of view, call it a ABA experimental design program, in which first A is a proper evaluation, then a rehab program, which is a laborious long program, and then A is again a repeat evaluation to see if there is improvement, if any. So that kind of a program, which is being done abroad also, and now is a focus. I hope I've been able to answer your question.
कह रही हैं बात वो ये है कि आप उसको होम बेस्ड रखेंगे since she is wheelchair bound. So would you keep it home based online, or the patient has to come to your place, AIIMS, to get that cognitive disability treated?
So, madam, the first visit
Would be at
would be
your
strongly suggestive to be in person for a thorough assessment of the needs. Cognition is a very broad perspective. It cannot have underlined segments that this is A, B, C, D, E, F, G, because cognition in MS is extremely heterogeneous and does not follow the same pathway of cognition in dementia syndromes like Alzheimer's and others. Their cognitive dysfunctions could be very variable, very, very subtle, only about subtle behavior, only about the subtle personality change. So the first, assessment has to be always preferably in person. Once you chart out the plan, developments have taken place where we can do online, even with the validated online tools as well, and they can definitely be charted out for individual patients. So another question, Dr. Ela, I would like you to answer, which is frequently asked, is about duration of treatment in it. A lot of patients have said, doctor, we are on treatment for 5 years, now someone says 6 years, I want to stop my treatment. So could you just elaborate from a perspective of treatment related to DMT, the duration?
So, duration of DMTs has to be individualized. there cannot be a one size fits all approach. So depending on the initial aggressiveness of the disease and multiple other risk factors that Professor Padma has already discussed, depending on the gender, depending on the initial attack frequency, and many other features including biomarker findings on imaging, we will decide the initial therapy, and subsequently the treatment is given for at least a few years before we reassess the patient, and depending on the other progression on imaging as well as repeat attacks, the decision to stop therapy is highly individualized, and that has to be taken on a case to case basis. So if someone has this concern, they are free to visit our clinic and we can give them a personalized advice regarding the total duration of treatment for that particular patient.
See, general what happens is that again broadly we have this no evidence of disease activity. So if there is this MEDA, there's nothing active happening. Person is taking this oral drug and person is over the age of 50 years now. So something very stable, from 35, 40, no attacks, meeting the medicines. Now she's crossed 50 years. Something where, there are places and MS clinics where they have stopped the medication. And there are a lot of centers who actually do that even after 2 years of being NIDA, but I don't do that. I do wait for 5 years, and I also take age into consideration. I never stop NIDA. I never stop the medication when they are 30s and 35 years. Because, by and large, this disease is most active in that particular age group. So though we have outliers of children with MS and you have very old people coming with MS, they are on the, they are on the ring side. They're not actually in the umbrella. So therefore, that's one criteria that we have. But it's again individualized. We have patients who've been on natalizumab for years, not had any relapse, doing very well. Their JC antibodies are holding on. They would not want to stop it. They do not want to rock the boat. And when you have finished your family, there's no question of, pregnancies and childbirths. And just like you're taking medication for diabetes and blood pressure, they would like to continue. So it's again an issue of MS centers now. Even when you repeat MRIs, Vipasha, you must note this. Even when you repeat MRIs, you don't give every time gadolinium. You should not. So earlier on, it used to be said that for an activity, we have to give this enhancement. We have to see it as one important factor. And the way it used to be repeated is different clinics had different paradigms. They were as frequent as every 3 months, every 6 months. The latest would be every year and count those lesions. Now, by and large, at least, when we're looking at a developing place, when cost again, as I said, the economics play a major role. We have, and I can talk on behalf of Dr. Rohit also, that we've never been too frequent in our MRIs, really. But yes, on certain varieties of DMTs, we would do it yearly basis. And when there is a necessity, there is a relapse which is significant, or whether there is a definitive concern that the score would indicate that you have to change your DMTs to another level, that time also we would do the MRIs. So the paradigm should never be that once I start on DMT, I have to do MRIs every 3 months, 6 months. No, the earliest would be a year, except when there are indications clinically indicated, and definitely not gadolinium unless until it becomes absolutely essential. Because we now have evidence that gadolinium accumulates and that causes problems in the brain.
I think important points that even the latest consensus recommendations from multiple specialists across the world, which were recently outlined, clearly say that gadolinium should not be done routinely, as ma'am said. The second thing is no need for doing repeated spine MRIs on follow-up. The brain MRI is sufficient to give us the information that we want. And as was rightly said, few of the drugs, for example, if you're on natalizumab, you have to get an annual MRI, and if you've turned positive or intermediate, and if you're still deciding to continue treatment till further decisions, you need to get a 6-monthly MRI brain. So these are few of the things which are important. I would also like to ask Rajesh, there are a lot of people who have questioned about bladder issues. What are the bladder difficulties, and how they can be tackled and what we should do to evaluate the bladder and then what treatments can be
Usually MS patient presents with myelitis or the spinal cord involvement, and even that cause bladder problems. That they can have a variety of symptoms like urinary urgency, urinary frequency, these symptoms, and they should visit urologist also. This should get evaluated, and depending on the treatment, medicine can be prescribed for the mild bladder symptoms, and if there is if there is bladder retention or something like that, even CIC can be advised. But
I should say, on the net. And this, I'm not talking about the Twitter or Facebook or patient narratives. Those may be misleading, and there would be a lot of misconceptions, especially, in certain diseases things. But I think genuine material you would always get on any of these major neurological academic or societies which exist both in the American, European, even Canadian, Australian. All of them are there. Okay, so that's not a problem. But the first question, I was not very clear of what you were trying to answer. I think you must take out your mask out and let me. It's a vaccine?
Something that someone from the States who had MS, she said it's very early stage. She said, BioNTech, the other half of Pfizer BioNTech for the mRNA for COVID.
Yeah.
So they've used the mRNA technique for these autoimmune diseases. They've seen success in AIDS. They've seen success in, I think, Parkinson's. But they've also apparently got to a stage 3 level with the FDA or the European equivalent on MS. But
oh, great. So no, we will
they've done it on mice and apparently a few humans. But for a general non-medical professional, what does that mean?
Yeah. Okay.
What is the how many, I know many drugs would fail in stage 3, but is that something that we should follow up on? What, just that kind of information.
So the vaccines part is very interesting, but not just MS, vaccines have been in sort of on board to find kind of a cure or to prevent something from happening. And this kind of expeditions have happened across a lot of diseases with definitely there have been success. For example, there is vaccine for human papilloma virus, so that
Fatigue actually reduces. So the only thing is to overcome that, mental block of doing the exercise. So being active, being functional throughout the day will actually help you to come out of this fatigue stage. So the message is stay active, stay motivated, and do a pacing of your day-to-day schedule, and then you can control your fatigue. And rest regarding the emotional part and the psychological part, Dr. Ashima can.
So first of all, what is important is that one has to identify the reasons of fatigue. If it is because the person thinks that there is nothing much which is happening and one wants to just lie down in bed. So one has to first of all, through our assessments, have to identify which are the good moments in a person's day or night when the person can do something productive. Of course, attitude makes a very big difference. Motivation makes a very big difference. We need to work on some of these variables to identify and then to find a solution for each of that. And if, of course, there are support groups, as they already have. And so sometimes it also helps when through a support group, one is able to identify one's problem and associate the problem and find a way to get out of this problem through a support group also. Dr. Rohit?
Thank you. I think you've all covered it as a comprehensive management plan, looking at the medications, they are causing issues, giving medications if the fatigue is significantly impairing the quality of life, and then putting some specific rehab measures and also behavioral modifications about this. So I think we've had most of the issues covered. Is there anyone who wants to ask from the audience before I request Dr. Padma to summarize? Yes, Padma.
राइट, वेरी इंपॉर्टेंट क्वेश्चन. तो एक तो है कि जो क्लिनिकल क्राइटेरिया में कोई 60 साल की उम्र में तो जॉइंट की प्रॉब्लम है, ऑस्टियोआर्थराइटिस है, उनको जकड़न है, वो अलग चीज़ है. इनकी जो जो ग्रुप हमने आपको बताया 20 साल, 25 साल, 30 साल, 24 साल की उम्र में सडनली एक आँख की प्रॉब्लम हो गया पेन के साथ, ये कोई झुनझुन हो रहा है, कुछ लगा कि क्लमजी हो गया, कुछ दिन में ठीक हो गया. वो अक्सर ये जो बहुत ज़्यादा प्रॉब्लम हो तभी वो लोग आते हैं दिखाने के लिए. कई बार अपने आप भी ये ठीक हो जाता है तो उसको भूल जाते हैं. तो जब आपकी जो सवाल आया कि क्या कैसे डिस्टिंग्विश करें कि ये एमएस है और कुछ नहीं प्रॉब्लम है, ये कंप्लेंट्स के अनुसार नहीं डिस्टिंग्विश होता है. ये कंप्लेंट में नहीं पता चलेगा कि ये ब्लड सप्लाई की प्रॉब्लम है, कोई ट्यूमर के वजह से है, कोई इन्फेक्शन है या एमएस है, कुछ और है. क्लिनिक्स में जब वो आते हैं, जो एग्जामिन हम करते, बाकी इन्वेस्टिगेशंस करते, उसके मुताबिक से ये डायग्नोसिस ऑफ मल्टीपल स्क्लेरोसिस बनती है. अब फिजिशियन के लेवल में भी समटाइम्स वो कंफ्यूज हो जाते हैं कि एमएस है या कुछ और है. सोचते कि वास्कुलाइटिस है, कुछ और ब्लड सप्लाई का है. कई बार उसको जब एमएस मिमिक्स कहते, और एमएस मिमिक्स में हमारा दूसरी वेराइटीज ऑफ डीमाइलिनेशन जो प्राइमरी है, एनएमओएसडी कहते, मॉ कहते, कई दूसरी एंटीबॉडीज के जरिए भी होता है. सेकेंडरी बोलते हैं, जो आपने घटिया की बीमारी में भी ये प्रॉब्लम्स होता है, वास्कुलाइटिस और सिस्टमिक डिसऑर्डर्स कहते. तो ये सब तो फिजिशियन के लेवल में ये डायग्नोसिस बनना चाहिए. तो हमारा अवेयरनेस में यही है कि अगर कोई ऐसी प्रॉब्लम अचानक हुआ, अपने आप ठीक भी हो गया, तो एक बार आप कंसल्टेशन के लिए ज़रूर आइएगा, ताकि हमें ये डायग्नोसिस नहीं मिस करना चाहिए. तो क्लिनिक उस खाली कंप्लेंट के लेवल में उनको पता नहीं चाहिए.
Before I request Professor Padma to wind up, there is one question which was most incorrectly answered. And I would like to definitely take up this question. We had asked a question about what is the most important factor for confirmation of a relapse? And I think a lot of people also consider fluctuation as a relapse and they get very worried. So the most important factor for confirmation of relapse to all sitting here and all who have joined online is the doctor's adjudication of the relapse. Your clinical history, your clinical examination, and the suspicion it plays on both sides is the most important factor. It's not the MRI, it's not any blood test which has been found to. So please, whenever you feel any kind of deterioration or anything that you perceive could be a my relapse, because you all are always worried and you are well informed, is to please go and meet your doctor and let him examine and take a good history before you plunge on to take a decision that I want steroids. So that's the most important factor. I would just also ask Dr. Padma before and to summarize and wind up and just touch down upon, because a lot of people have probably also not been exactly answering about MS and pregnancy, and that's sometimes a relevant question to married women and they want to know. So it's something you can just summarize, and then I would request you to overall summarize and we can.
तो प्रेगनेंसी इज इम्पॉर्टेंट, क्योंकि ये हम बात कर रहे थे कि लड़कियों में ज़्यादा होता है, यंग एज में ज़्यादा होता है, तो इट्स इनहेरेंटली अ पार्ट ऑफ लाइफ कोर्स. तो दिस इज़ इम्पॉर्टेंट. तो जो मिथ्स एंड मिसकंसेप्शन में ये है कि अगर एमएस आ गया तो प्रेगनेंसी नहीं आना चाहिए, अगर प्रेगनेंसी हो गया तो उसको अबॉर्ट करना चाहिए, और चाइल्ड बर्थ में प्रॉब्लम होगा, और अगर दवाई ले तो ब्रेस्ट फीड नहीं करना चाहिए, ये सब आता है. So that the actual facts now, after a lot of scientific evidence, is pregnancy plan कर सकते हैं. Planned pregnancy is better than accidental pregnancy anytime. तो अगर जो भी जिसका एमएस हुआ तो प्रेगनेंसी को ये नहीं कि उसके बारे में ही ना सोचे, नहीं, यू कैन डेफिनेटली प्लान इट, बट टेक इट एज अ प्लान्ड प्रोसीजर rather than an accidental occurrence. Second, अगर किसी को बहुत स्टेबल चल रहा है, नेडा जो हमने बात किया था, So in which case, if you plan a pregnancy, then there is a dialogue between the physician. पहले हम we used to think that DMTs को बंद करें, but now the latest evidence is, if there is a NEDA and you want to get into that pregnancy, you can continue a lot of DMTs. उसमें in fact पहले interferons and glatiramer थे in the 2020 guidelines. It is now within the guidelines that you can continue interferons and glatiramer through your pregnancy. So there is no reason to stop. And now in the same mold, even dimethyl fumarate has also come in, that you don't need to stop. Even leave that, even an aggressive MS, agar somebody is intent that no, I will have to get through the pregnancy, my age is getting older, I need to do that, and I'm pretty stable, then they actually even continue other drugs also. But it is a concern that they are walking the tightrope. The second important thing is, most of the data we have is in the first trimester. जो भी data आया, there is no exposure of these drugs in second and third trimester. So वो scientific data is not there. So therefore, the last of the AIIMS guidelines which have been updated have just come in 2000 and they've just been updated. And the last of the presentation of the major drugs was done in American Academy of Neurology couple of, I think, in February. So this data is coming in. Just remember that a lot of drugs have proven safe. You can continue. Worst is कि पहले हम सोच रहे थे pregnancy is very safe. Pregnancy probably is still safe, but relapses can happen. Depends on कि आपकी क्या स्थिति थी पहले. If the disease has been absolutely okay, then it is unlikely you will keep getting relapses. But if the disease have been aggressive, going off the DMTs, you may have relapse during pregnancy. You should be careful. Definitely all the drugs are on board immediately after delivery, because postpartum, you have gone out of what little protection you have. And a lot of drugs have been now shown to be safe even in breastfeed. Dimethyl fumarate ka, there has been a study where they have actually taken the breast milk and seen, and the percentage of this drug in the breast milk was minuscule. So there are a lot of scientific data which has come, which has made it safe. Now, if I compare, of drug in epilepsy, valproate, sodium valproate, वो right, left and center खाते हैं. And there are a lot of people who would, you would do level 2 ultrasound, look at the fetal abnormality, and you can continue that. उसकी जो teratogenicity propensity is 9%. And ये जो medicines DMTs में जो आ रहे हैं, they're much, much less. So there is a lot of concern about the DMTs, but we must take care of mother also, and mother can't have relapses and increasing disability. So pregnancy can be planned, can continue DMTs. It has to be a dialogue between the caregiver, the obstetrician, and the person with MS. And it doesn't mean that you will, you can't have a normal pregnancy. You should go into surgeries and the child will always be low birth weight. Ye nahi hai. Those factors are there. You should be aware. Normally, it can be a normal course of things. So I think we can now quickly sum up, and we have been through it. So isn't it exciting to, time to be able to actually even manage? So there's some very interesting and very intelligent questions that we face. The mRNA thing, we will read up more about it. And I think it is very heartening to see that. And I think it's cooled down. Bipasha, you got the rain in also. I think we had, I wish we had, I wish we had more people here, but I think ये शुरुआत है. So far, even public awareness, maybe there were not much of personal attendance. So maybe it is the start. So we have a lot of online questions. I was just reading, and there were immense number. I hope they have benefited out of it, and I'm sure we will be able to accommodate a lot of people who have been asking to come to the clinic now and take, and we will try and accommodate even the walk-ins. So thank you all very much, and God bless you all.
I also want to thank my all team members and our research team with young kids who work with us in research on MS, including cognition, biomarkers, and our clinical registry data. So I thank Gunjan, Manish, uh, Deepshika, who all are there, Risha, and who all are there, Pushpa, Ankita, and Shweta, and others who have been, a strong part of our research team with all of us. And hopefully the national registry will pave way for much more broader understanding of this disease in the next few years. So that's what I wanted to thank. You were speaking something.
Yeah, I wanted to thank all of you on behalf
of MSSI Delhi, especially of course Dr. Padma, Dr. Rohit, you, and Dr. Rajeev, Dr. Rajesh, Dr. Ella, is it? I haven't met you, but wonderful meeting you, and Professor Ashima. It's really wonderful. Today was a learning forum for me also. I learned so much more than what I know. Though I don't practice it, I don't tell them all these things, I send them to you people to say, but it has been a wonderful session. Next year, we'll be working very hard to get more people here so that they can face you and ask you one-to-one questions, which they always want to do. Thank you so much.